best of my knowledge, the author's study is the first to specifically investigate the effects of chronic and perioperative glycemic control in high-risk patients undergoing primary surgical closure of wounds. 79 patients were included. Wound dehiscence, infection, and reoperation rates were utilized as outcome measures. In this study, the authors demonstrated that preoperative and postoperative hyperglycemia, defined as any blood glucose measurement recorded above 200 mg per deciliter, and elevated hemoglobin A1C above 6.5%, were each significantly associated with increased rates of wound dehiscence, along with a trend toward increased rates of reoperation, although that did not achieve statistical significance. The authors also found that elevated hemoglobin A1C levels were associated with poor outcomes, regardless of their temporal proximity to surgical closure. In addition, elevated hemoglobin A1C was found to be predictive of perioperative hyperglycemia, as 88% of patients with hemoglobin A1C levels above 7% were hyperglycemic in the perioperative period. Looking at figure 1, it does seem to indicate that the steepest part of the curve begins at about 200, after which the complication rate rapidly increases for a given increase in glucose measurements. Identification of this cutoff level is clinically relevant and may have important implications in taking care of similar patients in our practice. Overall, the authors utilized a good methodology in this retrospective study. Patients' characteristics and comorbidities were similar amongst those studied. In addition, the authors successfully achieved freedom from infection and adequate debridement prior to primary surgical closure. However, there are a few points that deserve comments. Although the authors ensured negative cultures, this does not imply that wounds were completely proven to be free of biofilm, a chronic infection that could be identified with polymerase chain reaction testing. Therefore, it remained obscure which wounds in the study population were or were not infected by biofilm, a confounding factor that may have influenced the primary outcome measures. In addition, nutritional status of patient population was an unknown variable which may have impacted the studied parameters. Also, wound characteristics such as type, location, and size were not taken into account, partially sabotaging the conclusions. For instance, were all the wounds studied amenable to primary closure? Which ones were of diabetic, ischemic, venous, or combined etiology? Another significant concern was the use of non-standardized timing of glucose sampling that may have potentially jeopardized the conclusions. In addition, the authors arbitrarily used 5 days before and after surgery as an estimate of subacute perioperative glycemic control, and hemoglobin A1C data up to 4 months before surgery for assessment of chronic glycemic control, which could be the subject of a totally new study. Furthermore, only 64 of 79 patients had hemoglobin A1C levels, and only 36 patients had complete 5-day glucose data. Although this problem was partially overcome by demonstrating comparable complication rates between patients with complete data and those without, it may have skewed the data. Nevertheless, despite the constraints of a retrospective study and presence of several confounding factors, the current study found associations between glycemic control and wound complications, primarily wound dehiscence. The discovery of these associations is important as it provides the surgeon with information to assist in counseling patients and in stratifying patients' risk of surgical complications. This information is valuable as it relates to today's cost-sensitive healthcare environment with respect to prevention of operative takebacks secondary to wound complications in high-risk patients. Also, I agree with the authors that it's imperative to incorporate either internists or endocrinologists to assist with care of medically complex patients who are candidates for surgical closure. Finally, the current retrospective study has provided level 3 evidence and a good framework. However, prospective randomized controlled trials with a larger sample size, along with standardized sampling of perioperative glucose measurements and hemoglobin A1C levels in relation to their proximity to surgical closure, which would also take into account the effect of biofilm, specific wound types, and nutritional status of patients, are required to further determine the influence of glucose control on wound healing following primary surgical closure. Thank you.